Video, I'm going to be talking about the endocrine system disorders. You're welcome to take your notes as you follow along. You can also pause the screen and do a screenshot if you want to keep it for your record. So here we go. Disorders of the pituitary glands. So acromegaly. This is caused by too much growth hormone after the onset of puberty. So this is happening later in life, later in adulthood. The cause is unknown, or it may be from a tumor. So you're going to see growth changes that are irreversible, and you want to think that everything is enlarged. So think megaly, it's enlarged, it's big, it's giant, it's like, So the hands and feet grow larger. You have enlargement of the liver, heart, and spleen. You're going to have muscle weakness. Women get increased facial hair and amenorrhea. The men can become impotent, and they may also have vision loss. Your assessment, you want to encourage patients to share their emotional responses to sexual problems. You want to assess gait changes because they may be a fall risk, and the decreasing ability to perform activities. For your diagnostic test, they're going to do a growth hormone suppression test since the cause of this is too much growth hormone. So they're going to check those levels. Medical management, you can give dopamine agonists such as Dostanics, or you can give somatostatin analogs which inhibit growth hormones such as Sandostatin. Your nursing interventions, they're going to have muscle weakness, joint pain, and stiffness, so you want to assess their ability to perform ADLs. You want to encourage the patient to chew thoroughly due to an enlarged tongue. And you want to encourage range of motion exercises to prevent muscle atrophy. Their prognosis, even with medical or surgical treatment, physical changes are irreversible. So that's acromegaly. Remember, it begins after puberty and everything is enlarged. They're going to have a lot of muscle weakness, so you want to make sure you're ambulating them, giving them range of motion. And typically they will remove the tumor if that's what's causing it. If not, they're going to give medications which are going to help slow down the growth hormone. So that's acromegaly. Next we have gigantism. This is caused from too much growth hormone, just like acromegaly, but the difference is this is happening before puberty. So in this type of patient, they're usually abnormally tall. Their weight increases, but body proportions are usually normal. And despite their size, these patients are usually weak. So you want to assess the patient's understanding of the disease process. For their diagnostics, they're going to do the growth hormone suppression test. They're going to do surgical removal of the tumor if that's what's causing it, or irradiation of the anterior pituitary gland. Your nursing interventions are to monitor this child's height. So the child's height is recorded at each visit, and you want to stress to the patients, to the parents, the importance of regular visits to the pediatrician or the pediatric endocrinologist. So for gigantism, it's too much growth hormone. Before puberty, they're going to be really tall but really weak, and you want to keep recording their height. They'll go into surgical removal if the tumor is the reason why it's causing the growth hormone to secrete too much, and then you want to monitor the height. Next, we have dwarfism, and this is not enough growth hormone. So this patient's going to be short stature. They may appear younger than their chronological age. The sexual development is usually normal but delayed. You want to assess family history of dwarfism and determine when the child's growth retardation was first noted. The diagnostic test. The definitive diagnosis is based on low levels of growth hormones since this is the cause. Medical management. Replacement of growth hormone by injection, and you want to be aware that these injections are expensive and typically not covered by insurance. So for the nursing interventions, you want to be supportive. You want to encourage the child to wear age-appropriate clothing and engage in activities with peers. And for their prognosis, the lifespan is typically normal depending on the management of complications for musculoskeletal and cardiovascular systems. So for dwarfism, again, not enough growth hormones, so they're going to be short, they're dwarfs. They can give them growth hormone injections, but most of them don't do that because they don't grow too much taller even after that. So the main thing is to be supportive and make sure that they're wearing age-appropriate clothes. So those are your 3 disorders for the pituitary gland. Now we're going to move on to diabetes insipidus. So this is caused from not enough antidiuretic hormone from the posterior pituitary. And it causes increased urinary output, which results in dehydration. So for this type of patient, you're going to see polyuria, polydipsia. So they're going to be peeing a lot and they're going to be thirsty. They can have a urine output from 5 to 20 liters every day. They're going to have increased sodium in the blood, so they're going to have hypernatremia, and all of that can lead to a hypovolemic shock. So you want to assess, so the patient should be able to state the importance of not restricting oral fluids, because even though they're peeing a lot and they're drinking a lot, they might think that, well, if I stop drinking, I won't pee, but that's not the case. So they got to make sure that they're not restricting their fluids. So they're going to be tired, weak, lethargic. You want to assess skin turgor. You want to monitor the INO and weigh the patient daily. Their diagnostic test, they're going to run the urine specific gravity and the fluid deprivation test. Medical management, this is your desmopressin. This is DDAVP or vasopressin. You want to eliminate coffee, tea, and caffeine. So anything that's going to increase urinary output, you don't want that. They can give IV fluids of hypotonic saline or dextrose 5% in water if he or she is at risk for dehydration. So your nursing interventions, again, do not limit oral fluids in effort to reduce urinary output. You want to protect the patient from injury from frequent ambulation to the bathroom since they're going all the time. And you also want them to wear a medical alert bracelet. The prognosis, patients who survive are usually dependent on medication for the rest of their lives. So diabetes insipidus, they are urinating all the time. So that's from not enough ADH. So the opposite of that is your syndrome of inappropriate antidiuretic hormone. So now this is too much ADH. So the kidneys reabsorb more water, decreasing urinary output and expanding the body's fluid volume. So they're going to be hyponatremic. They're going to have water retention that progresses to water intoxication. They're going to have low salt levels, nausea, vomiting, irritability, confusion, tremors, seizures, stupor, coma, and pathologic reflexes. They're going to complain of cramping, anorexia, nausea. They're going to have headaches. The patient does not develop peripheral edema because excess fluid is accumulating in the vascular system, not in the interstitial spaces. So they're not necessarily going to have fluid or edema in their legs. It's because it's going to the vascular component. So for your medical management, they are going to do a diagnostic test of the serum osmolality and the urine specific gravity. They're going to be on fluid restriction, 800 to 1,000 milliliters a day. And for severe cases, it can be 500 milliliters a day. They're going to give hypertonic saline solution to correct sodium imbalance. They can give dimethylcycline, lithium, and furosemide to help push that fluid out. So you want to do a neurological exam and hydration status. You want to auscultate lung sounds because we said the fluid's going to the vascular component, not in the interstitial space. You want to monitor INO and electrolytes. And for their prognosis, so early diagnosis and medical management improve the prognosis. So again, this is SIADH. So this is your inappropriate antidiuretic hormone. It's caused by too much ADH. we saw in diabetes insipidus that was not enough ADH. So it helps if you learn one of the disorders, because you know the opposite is going to have opposite effects. So in one case, you have not enough antidiuretic, and the other case, you have too much. So it helps when you're studying to focus on one, and if you know the one, you're going to know the opposite. Okay, let's move on. Hyperthyroidism. So this is disorder of the thyroid. It's called Graves' disease, epithalamic goiter, or thyrotoxosis. And this is too much of your thyroid hormones T3 and T4, which leads to an exaggeration of metabolism. So this patient's going to have really high metabolism. So they're going to have bulging on the eyes, periorbital edema. The eyeballs are forced outward, resulting in incomplete closure of the eyelids. So they're going to be really dry. They can have ulcerations forming because their eyes are open all the time. For your assessment, they're going to have the inability to concentrate. They're going to be nervous, jittery, excitable. They're going to have weight loss. Even with eating so much, they're still going to be losing weight because they have high metabolism. This is hyperthyroidism. So your diagnostic tests, they're going to run the T3, T4, and TSH routine diagnostics. They're going to have the radioactive iodine uptake scan. And the goal for the medical management is to destroy enough of the hypertrophied thyroid tissue so that you can return to a normal thyroid level, which is called, this word here, euthyroid. So they're going to give drugs that block thyroid hormones, such as the PTU, the methimazole, and radioactive iodine, which you want to remember, it's contraindicated in pregnancy. Okay, nursing interventions. They're going to have a diet that's high in protein. They're going to have supplemental calcium and vitamin D, and the food should be soft and easy to swallow. So most of these patients are going to get their thyroid removed. So you have some pre-op and post-op nursing interventions. So for the pre-op teaching, you're going to teach them how to properly support the head while turning in bed or rising to a sitting or standing position. You want them to know they're going to do deep breathing exercises, and you're going to do voice checks every 2 to 4 hours. You're going to ask the patient to say ah, and then you're going to assess, did it get weaker and weaker? Because if that's the case, maybe something is blocking that thyroid. So you're going to do those voice checks. Post-op, so when they come back from surgery, you're going to keep the patient in semi-Fowlers. You don't want to hyperextend the neck. You want to make sure you have a suction apparatus and tracheotomy tray available at bedside. You want to check for bleeding at the sides and back of the neck and on top of the shoulders, because the gravity is going to drain that blood to the back. You also want to check chavostics and trousseau, because they may be in a hypokalemic state. If so, you want to give calcium gluconate, and you want to monitor for the thyroid storm. So you want to remember there are 3 complications of thyroidectomy. That's hemorrhage, tetany, and thyroid storm. So again, hyperthyroid is called Graves' disease. They have a very high metabolism, so things are running fast. Their blood pressure is going to be up. Their temperature is going to be up. They're going to have an intolerance to heat. They're going to be sweating. They usually have a lot of weight loss. So they need a diet high in protein because they're having this weight loss. They need vitamin C and D. You want to remember your pre-op and your post-op nursing interventions. So you want to make sure you're not hyperextending the neck. They're going to deep breathe. You're going to do voice checks. You're going to keep them in semi-Fowlers. You're going to have the suction and the trach tray ready for emergency situations. You're monitoring the calcium levels. You're doing that by doing the chavostics and trousseau. And you want to remember hemorrhage, tetany, and thyroid storm as your complications. So the opposite of hyperthyroid is hypothyroid. So this is not enough thyroid hormones. So everything's gonna slow down. Their metabolism is slow. In adults, this is called myxedema, and in children who are lacking the thyroid, it's called cretinism. So like I said, everything's slowing down. They're gonna have an intolerance to cold, they're gonna gain weight, they're gonna have constipation because their peristalsis is not as fast. So their blood pressure is going down, temperature's going down, they're gonna have mood swings and depression. The hair thins and it may fall out. They're gonna have bradycardia, exercise intolerance because they're tired. They're gonna have a decreased libido and they're gonna have excessive menstrual flow. Again, they're gonna test your T3, T4, and TSH levels. And for medical management, they're going to give levothyroxine. You want to give that on an empty stomach before meals, and usually lifelong therapy is required. So your nursing interventions, you want to keep the room at least 70 to 74 degrees because they're always cold. Their diet needs to be high protein, high fiber, and low calorie. Since they're prone to gaining weight, they need to be on low calorie diets. You want to increase their fluids. Regular checkups are essential because the drug dosage may need to be adjusted periodically. And they also need an adequate intake of iodine, which comes from saltwater fish, milk, and eggs. So this is hypothyroidism. Everything is slowing down, versus in hyperthyroidism, everything is going up. Next. So now we're going to look at the simple colloid goiter. So the goiter develops when the thyroid gland enlarges in response to low iodine levels in the blood, leading to overgrowth of thyroid tissue. So the clinical manifestation is based on the patient's physical appearance. So the patient may complain of dysphagia, some hoarseness, or difficulty breathing related to pressure on the enlarged gland. You want to assess the size of the goiter, do voice checks, and you want to check the adequacy of food and fluid intake. They're going to run T3, T4, and TSH levels. They can give the Lugol solution, which is your potassium iodide, which is the SSKI. And they're going to do foods high in iodine. Your nursing interventions are going to be to prevent complications such as bleeding, tetany, and thyroid crisis. And most patients can expect to live a normal life after adequate treatment of goiter. So this is simple colloid goiter. So far we've talked about the disorders of the pituitary gland. We talked about acromegaly, gigantism, and dwarfism. Then we moved on to your ADH hormones, which were hypo and hyper. So you had ADH, not enough. You had the inappropriate, which was too much. Then we talked about the thyroid. You had hyperthyroid, hypothyroid, and then your goiter. So this is part 1 of the video. Go ahead and click on part 2, and I'm going to resume the endocrine system disorders.